That's Goettl, Kyle Goettl. Sorry, just a play on Jim. When we're comparing traditional hyperbaric oxygen, or what we think of as traditional hyperbaric oxygen, compared to what I'm going to be talking about, topical hyperbaric oxygen, or TPOT, the difference I've already talked a little bit about. That is that one is a systemic treatment. There are issues with accessibility. There's no place in London where I'm from that we could say arrange to have someone go in locally and have hyperbaric treatments. There's quite a travel involved. There's the accessibility, as I mentioned, the cost and the labor. So we're talking primarily, at least in Ontario, that's usually in a facility that requires transportation to get to, and then a treatment occurs. But it is a growing treatment as well. Going back to the treatments that are registered, there's also a whole bunch of folks who are trying to promote it as a treatment for a whole variety of causes that I'm not going to get into, but those are the 13 that were currently being covered by the government to some degree. Topical hyperbaric oxygen, it is also hyperbaric oxygen. It's delivering oxygen under pressure at greater than 1 atmosphere, which is how it's determined if it's hyperbaric, far less than what is done on a systemic basis. And it is also, the thing that I'm going to talk about is that it's very portable, it's non-invasive, it's user-friendly, it can be done at home, it can be done by the patient themselves, and you will see positive effects within the first few treatments and then discontinued if you don't see those benefits. And again, here I want to highlight the whole systemic or team approach of how we look after wounds and move forward with that. Don't worry, a lot of my slides here at the beginning are kind of black and white, but it gets very colorful as we get a little further in. I've got 3 case studies that I'm just going to go briefly over that we'll see some hopefully great changes. So TPOT, I'm looking specifically at these particular things through the rest of the presentation. And again, it's hyperbaric oxygen, so technically it is promoted as being also one of those 13 conditions you could use this for as well. You do not want to use it, the contraindication, if you have an acute DVT or an acute thrombophlebitis. As in the case with all oxygen, you want to make sure you have a sign up, you want to make sure you're not using petroleum-based products and stuff like that. We used a 90-minute treatment once a day. It's possible you could use 90-minute twice a day. We tried that for a little while on one particular individual. It didn't seem to do any different anything different for our individual, so we just went to once a day. The idea with the 100% oxygen is that it does kill most of the organisms, or all of the organisms that you're worried about, the bacterial load that's in there. And it will do that for the 24 hours. So you're going to be getting rid of things such as the high-end dressings that have antimicrobial properties. You just need a simple moist dressing in between each treatment. So you're going to be saving a little bit there. It penetrates 2 millimeters into the wound bed. And I want to highlight here that you have to still weed the garden, so to speak. You still have to debride the wound base. You want to make sure you get as clean and as possible. And they suggest that you need at least a 50% wound bed, pink wound bed, to allow the oxygenation to filter through into the wound bed to help with the getting out of the inflammation stage. This particular system cycles up to 50 millimeters of mercury pressure, and it cycles back down again. So you do get a rhythmic, what's the word I'm looking for, squeeze, a rhythmic increase in pressure, which is helpful for edema. It's also helpful for reducing stress on the wound bed itself. You get a lot of congestion of fluid there as well, so it's going to help move and motivate that along its way as well. This I just took from the website. Again, I don't have any connections with the company, anything financially, but I took this picture because it does show the 3 options of how you want to deliver the system. I've used the one on the far right, that particular bag. To be honest, sometimes I find that a little more finicky, because if the patient moves a little bit, it can kind of break the seal. An alarm will go off, and you just go in there and readjust, and off you go again. But I did find that a little more finicky. What I've used the most is the chamber on the left, or the team that approach. We've used the chamber on the far left the most, and have had great success with it. The bag that's in the middle is a multi-purpose bag, so if I was to treat or to look at treating a sacral ulcer, that particular bag can be cut out to the diameter of the wound that you're treating, and then you use like a colostomy adhesive that goes around the wound, and this gets attached to it, and you can deliver the oxygen through that system to that site. Technically, the bag and that multi-purpose bag are supposed to be one-time use, or once every 24 hours, and the chamber, you use it continuously and you wipe it down each time you're ready to use it, or if you're going to use it in between patients. So all the pictures I've taken all over about this system and how we've been using it, I never took a picture of somebody's leg in there. So, so I'm demonstrating the principle with my arm. And this is the chamber itself. This is the computer module on the top. You hear computer module, you think, gee, that's going to be complicated. There's 3 buttons, and I've had a patient who ended up doing it himself, so I just put a sticky note on number 1, number 2, number 3, and he knew he pushed 1 till he was prompted, pushed 2 till he was prompted, pushed 3 till he was prompted. 90 minutes later, the alarm went off and we were done. Over here on the side is a humidification bottle. The oxygen, if you've got the luxury of piped in oxygen in your facility, good for you. We don't. We've only got a few rooms that have that. So we had to use an oxygen concentrator to deliver the oxygen in the room. If you've got walled in oxygen, you just run the oxygen from the wall right to the computer module and make sure your humidifier bottle is full. This particular piece here is the seal that would then go in here. And this is in this particular situation, is a latex dam that is measured to fit the size of the limb that you want to put in there. There is non-latex. I've had most success with the latex, but I think it had to do with my inaccuracy with measurement for the non-latex. It is a little more finicky and will tear a little more readily. And at this point, you put the person, their limb into this box. You snap it down with these seals. You've got a port on the side that you can access to build up and make that leg more comfortable in there with flannels or pads of some kind, so long as you leave that wound bed open to the humidified oxygen as it enters. The little case studies are coming up in just a moment, but first I want to just show you the two of the people that we'll be looking at are what you would consider diabetic foot ulcers. And this is the University of Texas Diabetic Foot Classification Scale that we use on everybody when they come into our program, because it helps us identify their risk, because that's the whole purpose of this tool. But it also is a teaching tool back to our folks to let them know how close they are to having, maybe suffering another amputation. It's a validated tool in that as you go from the top left to the bottom right, the likelihood of your amputation increases to the point of about 99% when you get down to this corner. The first person we're going to look at is in this category. I'm able to probe to the bone, and it looked like one of the pictures that Jim may have had in his presentation. And so we're going to look at how we've helped this gentleman as well as get his prosthetic limb. The third case is this gentleman over here. So he's one step sideways. It's not down to bone, but it is down to tendon in one location. And so we're going to start rolling now with case 1. So a 51-year-old man with, I'll let you read the rest of that. The thing is that I want to highlight is that he's been living with this ulcer on his other side since 2008, and at that, over the course of time, it was up to 8 centimeters by 4.5, close to the time when we met him. He also had that amputation on the left side. He lives in an apartment. I mentioned that scenario, people crawling to their bathroom. Well, he also had holes on both patellas because he would just crawl into the bathroom because he was told not to put weight through this remaining limb. This is the shape of the Charcot foot, which you've all seen Charcot feet likely. And this is the bottom of his foot after he's been prescribed the Charcot restraint orthotic walker. So when we look at why would we prescribe a Charcot restraint orthotic walker, just to follow up on what Jim was saying as well, things like the Aircast and those walking devices are really meant to support mid-foot and distal foot wounds. They're the gold standard for plantar ulcers would be a total contact cast, but most of us don't have access to a technician. And if the wounds are draining a lot, you don't want to necessarily put that in a cast either. So we started venturing with using the theory of what a crow walker is supposed to do and using that with our foot wounds, especially on the heel. And that's the case here. So right away we sent him, had the crow walker fabricated. So just having that alone, you can tell hopefully that depending on the lighting, he still has a certain amount of maceration around the wound. That wound bed is pale, it's a chronic wound. So when we talk about what is a chronic wound, that is a wound that has not continued to heal in a logical sequence of events. Something that hasn't closed in say 20% over the first course of 2 weeks, you would say it's a chronic wound. Interestingly enough, at the base of a chronic wound, the pressure of oxygen is often around 10. You need about 40 in order for the growth factors that are there in the wound as part of the inflammatory stage to start going into high production to help create the cellular structure necessary to support healing. And a lot of these wounds we're looking at, the vascular supply isn't there. The peri-wound area next to the wound, you're looking at traditionally about 60 as far as pressure of oxygen, and then you're looking at arterial blood supply at about being 100%. And so it gives a little more theory as to why hyperbaric oxygen, driving oxygen at 50 millimeters of mercury might help initiate some healing. And here he is. Any guesses how long this took to get to this stage? This is after the 5th treatment. So I hope you can see the differences. The lighting, again, I was wondering about this time of the day, there's a sun changing, but there's quite an undermined area along this wound edge. There's a big flap of dead tissue here. Right about here is where I could probe the bone. If if I could hold my hand steady. And so after the 5th treatment, this is when we saw him in clinic, and then we admitted him shortly after. And by the 5th treatment, I want you to notice that the wound edges themselves have progressed from being a cliff to being more beach-like. You can see the vascular nature of the wound bed, how it's moving forward, and just the color alone. You can actually make a case that there might be a blood supply in there now. There's oxygen there. It's actually red. It's not a dusky wound bed. The maceration, we're still continuing working with the wound fluid and how much is being put out, but I can tell you as the treatment goes on, while being in the crow walker to help compress, we're getting that fluid out, as well as through the compressive cyclical nature of the TPOT device itself. And I want you to also look and note where the hole was that went down into the bone. And that whole team approach, that as this wound changes, we're in constant dialogue as far as offloading inside that crow walker while this person learns to walk with a limb, an artificial limb. Here we are on September the 17th. And I believe this gentleman, if I check right, he was discharged on September the 10th. So we had him come back 1 week later. What we used the device for here was to jumpstart a wound. So I talked about that chronic state of the wound. We've jump-started that wound by providing the oxygen necessary to help it move past that chronic stage. And here he is continuing to progress. And here he is again, October the 18th. Again, he's an outpatient now without having the TPOT. He's just using his device and offloading the pressure. And here he was just back in February. The question was also earlier, like, what happens once it is closed? This particular gentleman with the shape of his foot does need a custom orthotic and likely a custom shoe if we can't find a shoe wide enough. But for all intents and purposes, there's no reason why he can't go on to a normal looking shoe. And that's the most popular complaint people have, is it doesn't look normal, the crow walker, compared to the other side. But again, I want to concentrate on the fact that we had a chronic wound since 2008, and we've had him in, jump-started that wound. We've had a really good outcome with this gentleman while still helping him with his prosthetic needs and getting back to a normal lifestyle. Case 2 is a 59-year-old man with a pack-a-day smoker, or he is a pack-a-day smoker, lost his leg in 2002. He lives quite a ways from London, so we started hearing about an ulceration. He was being followed for an ulceration on his residual limb. This is a man who already has a below-knee prosthetic device. When with him, the main complaint was pain. Lots and lots of pain, plus this wound. And I'll just skip on because we heard it was much worse. He comes into our clinic. We decide we need to admit this gentleman in order to take care of the needs that he is expressing. And so if this is the wound after he'd been, this is the day of admission. The nice thing for me is that I don't have to debride a whole lot there. It's down almost as much as I can go. I wouldn't be able to take that any further. And for him, again, it was very much a pain that was an issue. Here he is on April the 27th, so 2 weeks, I think, if my math is 14 days later. The improvement in the wound, again, trying to alleviate the pressure for one thing, but again, I want to highlight pain in this situation. We've been able to get a nice smooth wound edge. Things are advancing. Again, it looks a lot different than this. It's defined and it's moving forward, and the nature of this wound bed is really looking much improved. I mentioned pain, and so for the first couple of days, the first couple of treatments, while in the oxygen with a TPOT, we're looking at pain scales of still 9 out of 10. High doses of analgesics, of morphine derivatives. And by treatment 10, we're down to a pain level of 2 and eventually down to 0. So this gentleman, we were able to take away his pain, so whether it was just an ischemic type of wound as well, and we were able to help treat that by helping him move past that chronic stage and get the oxygen back in there. I'm not entirely sure. We were also helped to push some of that edema out, which would also help. But we were trying before to use those antimicrobial dressings. You think of the silver dressings, the iodine-based dressings, and even just simple gels, and he couldn't tolerate anything on that wound. So this is a huge step forward for this gentleman and improved his quality of life to the point of where he ended up getting this thing almost entirely closed last time back in June 2012. This gentleman had funding, so he is somebody who did go home with it, with WSIB, and continued to do the treatment on his own, and that's almost closed at that point. And finally, case number 3, which I think is an amazing one, not quite as graphic as number 1, but this gentleman lives alone, lives about an hour away, VRE, MRSA positive. I really want to look at his ejection fraction. It's 10%. He's above knee amputee, type 2 diabetes. His hemoglobin never hit 90 the whole time he was with us. So we admitted this really nice guy. And it's one thing to admit him and proceed with an above-knee prosthetic limb with an ejection fraction of 10%. So he had pretty limited goals. He was realistic. He wanted to access the bathroom, access the kitchen, and if possible, maybe wear it if he was taken out or went out somewhere. So this particular fellow, and again, the blood flow readings prior to being admitted, they couldn't find any major blood vessels going to delivering blood to his remaining foot. So this is after his remaining foot got cleaned up a little bit on admission. He's got these ischemic lesions on the toes, a bit of an ulceration that you can't see on the medial aspect of his great toe that does have some depth to it. And I don't know if you can appreciate it in the series of slides, the color of his foot as well, which is fairly dusky looking. This wonderful man had these wounds that are on the lateral side of his foot, and the precipitating factors and the way these wounds showed up on this foot were the same way that they showed up on his other foot that led to the amputation and a long hospitalization. And in this case, we had this one pretty well almost closed up from November 20th to December the 10th. And this is his heel. I want to go back to that again, that algorithm. There's things right away we could change about this. It's way too wet, so we want to make sure we dry that up. That's number one. But in this case, with very little blood flow, the normal treatment would be that we just want to make it as dry as possible. We don't want to harm it. We want it to dry up. It's an ischemic wound. There's no blood supply. But in this case, we cleaned it up and did the treatment because it's part of the whole foot. We put the whole foot in there as well. And this is it after only a few treatments. Again, a bit of debridement, but look at those wound edges. Look at the pink epithelial beds coming through. And take a look at that peri-wound margin as well. Good nursing care as well. But we're also seeing this a bit more pink coming up in the periphery. And I hope I'm not imagining that. I really believe that is what we were seeing. And here we are on December 10th. And this gentleman, after approximately 30 treatments, he was a complicated man over the Christmas holidays who hadn't been for an LOA, so his length of stay was a little longer. But we discontinued treatments before he was actually discharged. So it was a wonderful story, and he still beams when he comes back to clinic. Currently, the people who have the license for TPOT in Canada, and particularly in Ontario, are looking to try and make it an option for clinicians. So again, I said it right from the beginning, we don't use this with everybody. You have to go through the basics first, the whole team approach, the good wound care, the offloading of getting the right devices in there, but having that person buy into it too and having that trust factor. So they're trying to still get this as an option for people, just like the other adjunctive therapies. It's available as a private funded treatment, as I mentioned, and unfortunately there's no current studies on cost effectiveness, but other than what I've just told you anecdotally about reducing analgesics and also reducing the use of higher end dressings. And in my opinion, in summation, this has had positive effect on 2 wounds in patients with a critical limb ischemia, one with a chronic wound and a patient with a painful residual limb. And highlighting again and following up with Jim and many others have said today is that it's really about building that trust, that follow-up, knowing that the person you're looking after, you're in a team concept with, who's most important, which is the patient, that they have that trust in you, that you're able to deliver that you're able to find out even what their education level is, so you deliver that education in an appropriate manner so they're able to buy into this. And then knowing that you're there for them if they do have issues over the course of time. And that all being said and done, we have great outcomes with the use of this device. And these are just a few references. And thank you.
Do you have questions?
I'm glad you're not asking me to cite them all. Yeah, but definitely for sure, yes. Yes. And so as part of that group that did the validation of the statements related to human use, but there's a lot of literature that shows use on dermal wounds on pigs and stuff like that. There's been a lot of research in that. Is that what you mean, like as far as that basis? Control studies. So on animals, I can't say specifically. I would say if you want, I know their sponsors here today would be to go to their table and ask specific questions like that. When we're looking at those statements about the strength of the literature on it, there aren't any randomized control studies using this versus not using that, or using something else in a control. And that's the unfortunate thing when you're talking about wound care products sometimes, is if you've got a good thing and the clinician is using it, and you see good positive results, it's hard to hold that back when you know it may be having a good result for someone.
Well, I buy that, except that here's an example. We can do a controlled study on animals, and there's that device that we want to determine whether or not your facility is appropriate.
So on the animal, again, that's something very specific I would ask, you know, if you want to ask the folks, I don't know about that. Yep. Yes?
I was just wondering if you would expect to see the same results if the patients weren't as administered as inpatients.
That's a good question. So there were some designs, study designs using larger human populations for different things. And at least one that I know of, and it kind of did fall apart because, and it's my theory, and I think others have it as well, as far as the team effort of who's looking after that and who's taking ownership of something. You can see that from prosthetist to prosthetist in one facility. You can see that from nurse to nurse from one shift to the next shift, is who's actually taking ownership and professional action and pride in looking after something. So if you were able to remove all those variables concerning that, I would say there shouldn't be any change if it's being done in the community. And there are a lot of exceptional nurses in the community who would be easily looking after this, and family looking after this in the community would also be appropriate. Oh, yes. I was fortunate enough that I've done some things with wound care that I was asked would I want to try it. And so I said, well, I'd say yes to almost anything. So I was able to get the device, and we had some encouraging results. I had a guy in mind when it was offered. I said, well, can I borrow one? And again, we had one of those case studies was one of those gentlemen, and I've just not said I was done with it yet. So, so the folks at TPOT know I have it. And I imagine if when they're able to get this in the community, or at least available that it can be part of an OHIP prescribed treatment, they'll probably want it back real soon because it'll have to be used in the marketplace, I'm sure. But I'm still very thankful that we have it. It's borrowed. Yes?
What's the cost of a unit?
Again, I can't say specifically, but again, I'm sure if you ask the folks because I want to make clear I'm not a representative of the folks that supply it or manufacture it, but yeah. It's probably too much more than I can afford, but yes? Sorry? A regular treatment, you can change the treatment time, I think, down to 30 minutes or 60 minutes. It goes in those 30-minute intervals, I believe. We just use the standard 90 minutes, and that's what's usually recommended. The one thing I didn't mention was if you had a particularly painful wound, for whatever reason, while they're in that treatment, you can take saline or just salt water, sterile water moistened gauze, and lay that over the wound just to enhance humidification. The oxygen is still going to get through there as well. Just a tidbit if you end up using it and that were the situation. Great.
Thanks very much.
Thank you.
Thank you very much, Kyle.